Hello, good afternoon. I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure today of moderating our multidisciplinary breast cancer tumor board. And I'm going to ask our faculty to each introduce themselves. We have some very distinguished faculty with us today. So we'll start out with Dr. Joyce O'Shaughnessy.
Joyce O'Shaughnessy, Baylor University Medical Center, Texas Oncology, and U.S. Oncology, and I'm chair of the U.S. Oncology Breast Cancer Research Program.
Hi, Terry Mamones, breast surgical oncologist. I work at the Orlando Health Cancer Institute in Orlando, Florida, and also chair the breast committee for NRG oncology.
Hello, I'm Dr. Frank Muccini, radiation oncologist. I work for Genesis Care in Michigan.
Hi, I'm Dr. Maxine Chalkelson. I am the Director of Imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I'm a breast imager and a PET reader.
40-year-old premenopausal woman that has a newly diagnosed encapsulated papillary carcinoma and DCIS that's ER and PR positive. She's had a lumpectomy and does have a positive margin for the DCIS and had 2 lymph nodes sampled, which did not have any evidence of metastatic disease. The focus of our first discussion is going to center around optimal radiation therapy. So a few more details about the patient. She had a palpable lump for the preceding 3 months, and she has an excellent performance status. As I mentioned, she is premenopausal, no significant family history. We're going to go over the imaging here in just a bit, but a few details about the biopsy that was completed in January of 2021, demonstrating ductal carcinoma in situ, cribriform type, ER 90%, PR 90%. Then in February, she underwent lumpectomy and sentinel lymph node biopsy, which demonstrated the presence of an encapsulated papillary carcinoma, which was intermediate grade, measuring 15 millimeters, with associated DCIS. Prior biopsy site changes were identified on the pathology specimen, but it was noted that there was a posterior margin positive for the DCIS. Dr. Jockelson, if you'll point out some of the important images, thank you so much.
Certainly. So these are the MLO images from her mammogram, and she has a pretty fatty breast, but you can see she has a triangular marker denoting the site of the palpable abnormality. She has a high density lobulated mass, and then you can see a few calcifications in and around the mass. And then I think the next slide just shows the craniocaudate view. No other suspicious findings anyplace else in the breast.
Okay, perfect. Thank you so much. So Dr. Mamones, the plan is for a re-excision given the positive margin for DCIS. And we wanted to hear Dr. Vicini's recommendation for optimal radiation therapy after re-excision.
Yeah, so I think it's reasonable to re-excise. There's a positive posterior margin. Looked on the mammogram that the lesion was somewhat posterior. So, unless sometimes the surgeon says, well, we went down to the chest wall, there's not much more to do. I think typically we'll go back and re-excise. And also, if I can comment, also with the use of sentinel lymph node biopsy in this case, where it was essentially an encapsulated papillary, I think some will do a sentinel lymph node biopsy for a palpable mass when the DCIS is palpable. You can argue it both ways to defer and see if there is invasion on the excision and then go back and do it. But I think it's not totally unreasonable to have done it up front. But that's so far what I would recommend: re-excision and then radiation.
Thank you so much. Dr. Vicini?
I definitely agree with Dr. Mamones. I would ask for a re-excision, and then depending upon what we see from the re-excision obviously would dictate whether or not to proceed with radiation therapy. This patient would qualify for conventional standard whole breast radiation, meaning given over 5 to 6 weeks, but also would qualify for accelerated whole breast irradiation, meaning delivering the entire treatment in about 3 weeks, 16 treatments, but similar to the Canadian fractionation schedule. The only question here in my mind is whether or not to add a boost to this patient. And again, that would be based upon seeing what was found at re-excision. Even though we do have data supporting accelerated partial breast irradiation, I think in this setting and this patient, I'd be a little bit hesitant until I see the pathologic findings at re-excision. But again, just standard whole breast irradiation, whether or not it's accelerated or conventional, given over 5 to 6 weeks.
Perfect. Thank you so much. Dr. O'Shaughnessy, I wondered if you might comment about whether or not this is a patient you would consider genetic testing, given that she's 40 years old, no family history, of course, but she is 40 years old. Is this a patient that you would consider genetic testing?
Yes, yeah. The fact that she had DCIS, I definitely would recommend it to her. And then I probably would talk to her about tamoxifen as well, because she's so young, and then encapsulated papillary carcinoma, is a bit of a controversial kind of a gray zone lesion, but kind of more towards DCIS in this setting. I think you can have some invasion with it as well. It's favorable prognosis regardless, but she has no invasion, so treating it more like a DCIS. So I'm not apt to send, for example, a 21 gene recurrence score or a 70 gene signature. I'm not apt to send anything like that because I wouldn't consider chemotherapy for this patient. But I think I would talk to her about tamoxifen, 5 years of tamoxifen for risk reduction.